Dear Alex, good afternoon. First of all, I would like to thank Professor Kotsis for his honorable invitation and Professor Anja for her kind words. I will begin my presentation with the famous quotation that man is as old as his arteries. But let's talk about stiffness and vascular aging. What we know about them. Vascular aging and arterial stiffness is the same thing. The mechanisms comprise of vascular aging comprising of arteriosclerosis and atherosclerosis. Arteriosclerosis is characterized by thickened vessel wall, and atherosclerosis it is characterized by the accumulation of the plaque. For that reason, in arteriosclerosis, we have a more stiffened vessel, and by this way, the blood flows with high velocity, causing several damage in several important human organs. For that reason, aortic stiffness is an independent predictor for coronary events, for fatal stroke, and for mortality. And it has a very good predictive value, especially in patients of lower cardiovascular risk, such as those without diabetes, without hypertension, non-smokers, and younger patients. How can we calculate the arterial stiffness, the vascular aging? First of all, we can combine age with traditional cardiovascular risk factors. The second way is to directly measure arteriosclerosis by the pulse wave velocity, and the third way is to combine traditional cardiovascular risk factors and pulse wave velocity. We can calculate vascular aging in different regions and sites of different arteries. We can use several methods, but the gold standard is the pulse wave velocity measurement by, again, several methods and several devices. What is early vascular aging? 15 years ago, Professor Kotsis wrote in an article that in susceptible individuals, the vascular aging process seems to be accelerated. This means that the chronological age does not truly reflect the actual status of the aging process at the vascular level. And a patient with early vascular aging has higher vascular aging than they expected according to his chronological age. Factors contributing to the EVA, to the early vascular aging, are either modifiable, such as environmental factors or diseases, or non-modifiable, such as sex, chronological age, or genetics. Is it important to calculate vascular aging? Of course it is, because vascular aging improves the perception of cardiovascular risk, facilitate the communication with the patient, and benefit by this way the adherence to the therapy. For example, a lady of 50 years old, smoker, with high blood pressure and cholesterol, she will not understand if we tell her that you have 4% to die from cardiovascular disease in the next 10 years. She will always understand if we told her that, look, you are 50 years old, but your arteries is 70 years old. The second reason is that vascular aging tells us the whole history of the arterial wall damage, not only a snapshot, and it is less prone to the fluctuations over time like blood pressure, glucose, or lipid profile. The third reason is that patients with healthy vascular aging have 70% lower risk for future cardiovascular events, and on the other hand, patients with EVA have 3 times higher risk to develop cardiac events in the future. The 3 major factors of arteriosclerosis, arterial stiffness, is dyslipidemia, diabetes, and high blood pressure. However, in the recent guidelines for dyslipidemia and diabetes, vascular aging, arterial stiffness is not included as factor in the definition, in the classification of cardiovascular risk. Only in the recent hypertension European guidelines, they use a pulse wave velocity cutoff as definition for hypertension-mediated organ damage, and thus classify their patient in higher risk. In order to calculate pulse wave velocity, we need expensive devices, qualified medical staff, and a lot of time. For that reason, we can use the blood pressure. How can we calculate the stiffness by 24-hour ambulatory blood pressure? There are three ways. The first is the pulse pressure is a well-known arterial stiffness index, which reflects the increase of arterial stiffness and is associated with adverse prognostic impact, especially in the middle age and in older population, in older people. The second way is to calculate the ambulatory arterial stiffness index, AZ. We can calculate it by the formula 1 minus the regression slope of the diastolic to systolic blood pressure over the 24 hours recording period. It can take values from 0 to 1 with high readings suggestive of stiffer arteries, and firstly it was designed as a predictor of arterial stiffness, as elasticity in the arterial system influences both height of diastolic blood pressure as well its relation to systolic blood pressure. Is a good predictor for future cardiovascular events. For example, is a meta-analysis that shows 30 and one other 66% higher risk for stroke. However, the correlation with the gold standard pulse wave velocity is too low, 0.3. Additionally, AZ has several other disadvantages, such as it is strongly dependent with an optional blood pressure for in the hypertensive patients. There is no significant relation with the left ventricular mass, is affected importantly by other factors, and the most important is that other important predictors of vascular age have not been considered. And here comes the new early vascular aging ambulatory score from the ABPM. Especially in a recent article, Consensus of the Vascular Age Network, it is proposed as an alternative method to identify patients with early vascular aging. What is early vascular aging ambulatory score? It's a risk score that was developed by Professor Coaches and Professor Anja's team using 24-hour blood pressure parameters such as mean systolic, diastolic, and heart rate, and other cardiovascular risk factors such as sex, age, diabetes, body mass index, and estimated GFR. We also create an application where you can put these variables, and for example, in this patient, we can say that he has 74% possibility to have early vascular aging. Additionally, this score has very good accuracy, sensitivity, and specificity, and more recently, it was externally validated in a population of 900 patients, again with excellent sensitivity and very good specificity. Following their authors' directions to be evaluated this score in other hypertensive target organ damage, we examine it in stroke patients. In a pilot study, we find a positive, statistical significant, low but positive correlation with pulse pressure, and additionally a positive correlation with the severity of stroke, or especially in the atherothrombotic ischemic strokes. In this context, there is under progress an international project which evaluates the early vascular ambulatory score in acute ischemic stroke patient under the auspices of the Hellenic Stroke Organization Research Network, in which participate clinical centers from seven different countries with 3,000 acute ischemic stroke patients. And now let's talk. Okay, we found in that the patient has a great possibility of early vascular aging. What will we do with that? Of course, the vascular aging must be slowed down or even prevented. And the most important is that this to be done in the first stages, before in the preclinical stages, before the index disease developed, before the stroke, before the MI, before the diagnosis of the hypertension. This can be done by the adoption of a healthier lifestyle with exercise, less salt, Mediterranean diet, stop smoking, and of course with pharmaceutic therapies. There are a lot of agents under investigation, but we will talk about diabetes, hypertension, and dyslipidemia. What we know that several antihypertensive and antidiabetics have favorable effect on the arterial stiffness. To begin with hypertension, convertive enzyme inhibitors, angiotensin receptor blockers, and mineralocorticoid receptor blockers improve arterial stiffness independently of the decrease of the systolic blood pressure. On the other hand, for diabetes 2, the three major class of SGLT2 and DPP4 inhibitors and GLP-1 has favorable effect on arterial stiffness. SGLT2 through mimicking nutrient deprivation state. There are small studies about dulaglutid and liraglutid. And for dyslipidemia, it is well known that statin therapy has a favorable effect on improvement of arterial stiffness. Additionally, in the last PCSK9 inhibitors, after 2 and 6 months therapy, associated with improvement in arterial stiffness, again independently from lipid lowering. But okay, we decrease arterial stiffness. Do we have clinical benefit? This is what we should really know. But again, we may never know. There is only one randomized clinical trial in which patient was randomized according to the therapeutic strategy targeting either normalization of pulse wave velocity or treating hypertension according to the recent guidelines. And the investigators succeed to stabilize pulse wave velocity through mainly decreasing the blood pressure, but the pulse wave velocity normalization strategy did not result in statistically significant reduction in cardiovascular outcomes. So how we can use this early vascular aging score and next by the calculation of pulse wave velocity, the early vascular aging. We can use it at the stage 1 hypertension or the isolated systolic hypertension in order to take our decision to initiate antihypertensives. According to the European guidelines, we can use the cutoff of the pulse wave velocity in order in a grade 1 hypertension to start antihypertensives without waiting the lifestyle intervention to succeed. And additionally, in the middle-aged patients of intermediate cardiovascular risk, this score can help us at the discussions with the patient about our therapeutic in order to initiate a pharmacological treatment such as statins or antihypertensives, or for further investigation in order to calculate his or her cardiovascular risk. And I will close my presentation telling that arteriosclerosis, vascular aging is equally relevant as mechanism of age-related diseases. Unfortunately, have been traditionally investigated by separated scientific groups of that atherosclerosis, which has led to incomplete inclusion of vascular aging into major clinical guidelines. We need further studies to clarify the best strategy to quantify and treat early vascular aging. However, we can say that antivascular aging is quite popular among the general population, and we can calculate it with several methods, and we can use the new EVA score by 24-hour ambulatory blood pressure monitoring, and this could make the difference in the cardiovascular prevention. Thank you for your attention.